Imagine going under the knife to fix what you are absolutely convinced is vaginal looseness. Like you go through this totally grueling, weeks-long recovery.
Right, no exercise, no intimacy, just dealing with the pain of dissolving stitches.
Exactly. And then you find out a few months later that your muscles were actually too tight all along.
Yeah, that is a devastating realization for a patient, and it happens way more often than you'd think.
It really is. So today, for you listening, we are looking at the often misunderstood and honestly sometimes controversial world of pelvic floor surgeries.
It's a heavy topic, but a really necessary one.
For sure. Our mission for this deep dive is to answer a very specific, highly searched question that we've pulled from a massive stack of medical guidelines, clinic leaflets, and academic papers. And that question is, can perineoplasty be combined with vaginal tightening?
I mean, most people just assume that combining these procedures is, purely a cosmetic endeavor.
Right, like a facelift for the pelvic floor or something.
Exactly. People hear terms like vaginal tightening and immediately picture vanity or some kind of external pressure. But the clinical data paints a radically different picture.
Yeah, it really does.
We are looking at a really complex intersection here. It's reconstructive surgery, functional anatomy, and severe quality of life issues that stem from trauma, structural failure, or even profound nerve damage.
Okay, let's unpack this. Because to answer whether these two specific procedures can be combined, we first have to map out the anatomical real estate, right?
We do, yeah. The terminology can be incredibly confusing.
It is. The medical literature and the clinic marketing brochures we looked at use terminology that seems to actively contradict itself sometimes. So we need to distinguish between what these surgeries are doing geographically versus what they're doing mechanically.
So let's break down the functional geography. A vaginoplasty, which is the clinical term usually associated with vaginal tightening, addresses the entire internal vaginal canal.
Meaning the inside part.
Right. The surgeon is actively excising excess vaginal mucosa, which is that internal lining, and pulling the underlying muscles closer together. This physically reduces the diameter of the entire passage.
Okay, got it.
A perineoplasty, on the other hand, deals strictly with the perineal body and the external opening, which is called the introitus.
I always think of the pelvic floor like a load-bearing architectural structure.
Oh, I like that.
Yeah, so a vaginoplasty is like renovating the interior hallway, bringing the walls inward. But a perineoplasty, or perineorrhaphy, is repairing the structural integrity of the front porch and the foundation doors.
That's a perfect analogy, because during a vaginal delivery, that front porch takes the brunt of the impact.
It totally does.
The perineal body sustains lacerations, or it's the site of an episiotomy, which is a purposeful cut made to accommodate childbirth.
And the mechanical issue is that those tissues don't always fuse back together correctly, do they?
Not always, no. So a perineoplasty aims to repair that specific foundation. The surgeon cuts away the excess scar tissue, removes skin tags, and sutures the separated underlying muscles of the perineal body back together.
But importantly, a perineoplasty does not touch the interior hallway.
Correct. It only alters the external opening.
But wait, if a perineoplasty strictly rebuilds the outside opening in the perineal body, how are clinics legally advertising it as a tightening procedure?
That's where the confusion comes in.
Like, if it doesn't touch the internal canal, calling it vaginal tightening feels almost like a bait and switch for patients expecting a full internal reconstruction, you know?
It does feel that way, but it comes down to functional perception versus anatomical reality. The physics of intimacy rely really heavily on friction at the introitus.
At the entrance.
Exactly. By repairing the muscles of the perineal body, the surgeon effectively narrows that external doorway. And that decreased diameter at the entrance creates a significant increase in friction. So, the patient experiences a profound feeling of tightness during penetrative sex, even though the deeper interior anatomy remains completely untouched.
Wow, okay. So the sensation of tightness is achieved by altering the gateway, not the corridor.
You nailed it.
Well, that distinction directly answers the core question of our mission today. Because if one procedure fixes the structural foundation of the doorway and the other fixes the internal hallway, it makes perfect clinical sense that a patient suffering from comprehensive pelvic floor trauma would need both done simultaneously.
They absolutely do, and they frequently are combined. In the surgical realm, this combined approach is often referred to as a colpoperineoplasty.
And the guidelines we read from the NHS and the British Society of Urogynecology show that this combination is basically the routine standard of care when addressing a posterior wall prolapse, right?
Yes, it is the gold standard for that specific issue.
So let's talk about the mechanics of a posterior prolapse or a rectocele, because the physical reality of this condition is pretty intense.
It really is.
You have this strong layer of connective tissue, the fascia, that acts as a retaining wall between the vagina and the rectum. And when that fascia is compromised, whether by the sheer force of childbirth or just tissue degradation, that retaining wall essentially caves in.
Yeah, the bowel literally loses its structural support and physically bulges forward into the back wall of the vagina.
Which sounds incredibly uncomfortable.
Oh, patients live with a constant heavy dragging sensation in their pelvis. They experience chronic difficulty emptying their bowels because the anatomy is actively obstructing the process.
It is.
And in severe cases, there is a visible tissue bulge extending completely outside the vaginal opening.
So to fix that, a surgeon has to go in and perform a posterior repair. They separate the vaginal skin from that weakened fascia, rebuild the retaining wall, and basically stitch everything back together.
Yep, that's the first, yes.
And they combine it with the perineoplasty, because if you rebuild the internal wall but leave the external foundation compromised, the structural integrity of the whole repair is at risk.
Exactly. If we connect this to the bigger picture, the tissues in the pelvic region are part of an interconnected suspension system. They don't operate in isolation.
Right, it's all connected.
If you look at the impact of menopause, for example, the drop in estrogen doesn't just affect one isolated patch of tissue. Estrogen receptors are densely packed throughout the entire pelvic floor.
And when those receptors are deprived of the hormone, the entire system undergoes a process called atrophy.
Right. The tissue literally thins out. It loses its elasticity, its blood supply diminishes, and it stops producing natural lubrication.
Which our sources clinically categorize as genitourinary syndrome of menopause, or GSM.
Correct. When a patient is dealing with a systemic issue like GSM or widespread trauma from a difficult delivery, addressing only one aspect of the anatomy is just functionally inadequate.
So if a surgeon tightens the internal canal, but ignores a compromised perineal body, the patient will probably still suffer from that dragging sensation or urinary incontinence or diminished sensory feedback.
Exactly. The surgical approach has to treat the entire architectural unit.
Now, if you are considering this combined colpoperineoplasty, you need to understand that this is a major, highly invasive surgical intervention. Reading the operative details in the sources makes it clear this is not a casual lunch break tweak.
No, not at all. It is a major operation.
The surgeon is making deep V-shaped incisions to carve out scarred or stretched tissue. They are using deep absorbable sutures to mechanically force separated muscles back together.
And the recovery protocol really reflects the trauma of that intervention.
Right.
Patients are often placed under general anesthesia.
Right.
Post-surgery, they might require a urinary catheter for a couple of days because the localized swelling basically shuts down normal bladder function. Surgeons frequently pack the vaginal canal with gauze to act as an internal compression bandage just to mitigate severe bleeding.
And those deep absorbable stitches dictate a really rigid recovery timeline. It takes 4 to 6 weeks for that tissue to biologically fuse and heal.
It's a long process.
Yeah. And during that window, patients are restricted from any strenuous physical activity, lifting, or exercise. And they must absolutely abstain from intercourse for at least 6 weeks to prevent physically tearing the surgical reconstruction apart.
Beyond the prolonged recovery, the surgical risks are substantial. We are looking at potential complications like postoperative infection, hematomas, and most critically, dyspareunia.
That's painful intercourse, right?
Yes. If the surgeon overcorrects, meaning they excise too much mucosa during the vaginoplasty or suture the perineal body too tightly, it can render penetrative sex permanently painful or even anatomically impossible.
Wow. Because surgery requires such a massive physiological toll and carries the risk of permanent pain, it's entirely understandable why patients are desperate for alternatives.
Absolutely.
The clinic leaflets we reviewed are heavily pushing non-surgical tools like CO2 lasers, radiofrequency wands, and PRP injections, which are often marketed as the O-shot.
Yes, those are very popular right now.
But wait, I have to challenge the premise of these treatments based on the mechanisms we just discussed.
Okay, let's hear it.
If actual surgical tightening requires a scalpel to remove excess skin and, stitches to pull a torn muscle back together, how can a laser wand claim to tighten a pelvic floor?
Right.
Is that just a marketing gimmick? Like, if collagen degrades over time anyway, aren't patients just renting this supposed tightness for a few months before they have to go back and pay for another session?
I really appreciate that critical thinking because it is a vital distinction to make. Non-surgical tools absolutely cannot alter the physical anatomy.
Right, they aren't cutting anything.
Exactly. A laser will never pull a separated perineal muscle back together, and it definitely won't reconstruct a collapsed fascia in a grade 3 prolapse. What these tools actually do is harness the body's inflammatory cascade through controlled thermal damage.
So they are essentially burning the tissue on a microscopic level to trigger a healing response.
Yes. Specifically, when a provider applies a CO2 laser to the vaginal epithelium, the energy is absorbed by the residual water in the connective tissue. This creates thousands of microscopic thermal injuries. In the immediate aftermath, this triggers localized edema, or swelling, which is the first phase of the inflammatory response. But as the tissue repairs itself, it stimulates fibroblasts to synthesize new structural proteins.
Right, this is the neocollagenesis mentioned in the papers. It's basically the exact same biological mechanism as getting a Fraxel laser on your face to smooth out wrinkles, just applied to a mucosal membrane.
That's a great comparison. Furthermore, the thermal injury promotes neovascularization, which is the aggressive formation of new microscopic blood vessels.
And this is where the functional shift happens, right?
Yes. By increasing the blood supply, the laser treatment actively thickens the stratified squamous epithelium. It revitalizes the cellular environment, which brings back healthy levels of glycogen.
So let's break down why glycogen matters to the patient experiencing discomfort. It isn't just a structural change, right? It actually changes the biome of the tissue.
Exactly. Glycogen feeds lactobacilli, which are the healthy bacteria essential for maintaining the acidic pH of the vaginal canal.
Oh, that makes sense.
When the lactobacilli thrive, the tissue's natural moisture barrier is restored. The dryness and the microabrasions associated with genitourinary syndrome of menopause disappear. The tissue becomes thicker, more robust, and significantly better lubricated.
So the non-surgical tools are fundamentally improving the quality and the metabolic health of the tissue, making it plumper and more resilient rather than mechanically pulling it tighter.
Yes.
It's treating the degradation of the tissue, not the structural collapse of the anatomy.
And that leads directly to the most critical nuance in our entire stack of research. Vaginal tightening is not a recognized medical diagnosis.
It's just a symptom description provided by the patient.
Exactly. When a patient sits in a clinic and says, "I feel loose, I need to be tightened," that sensation of looseness might not have anything to do with structural laxity.
That was the biggest revelation in the source material from the Women's Health Clinic for me. A patient's internal perception can be wildly disconnected from their physical reality.
The clinical assessment is where this gets incredibly complicated. A loss of friction or a feeling of hollowness during intimacy is often a neurological issue, not a geographical one.
How does that happen?
Well, during a complex vaginal delivery, the baby's head can physically compress the pudendal nerve against the pelvic bone. This causes demyelination or aggressive stretching of the nerve fibers.
So if the pudendal nerve is damaged, the action potentials, like the electrical signals, aren't reaching the brain effectively.
Right. The brain is starved of sensory feedback. It isn't registering the friction that is actually occurring. But the brain doesn't interpret this lack of signal as, my pudendal nerve is compressed.
Right, it doesn't have that vocabulary.
It interprets the lack of physical sensation as the anatomy must be too loose. The patient feels a lack of contact, so they assume the walls are too far apart, when in reality the muscle tone and the physical diameter of the canal might be perfectly intact.
That is wild. The brain is literally misinterpreting localized numbness as a loss of physical structure.
It is.
And if a surgeon doesn't catch that, they might perform a highly invasive vaginoplasty on a patient whose anatomy is completely normal, literally trying to fix a nerve injury with a scalpel.
Which will ultimately fail to resolve the patient's primary complaint and just expose them to unnecessary surgical risks. And the neurological illusions don't even stop at numbness.
Right.
The exact opposite, problem muscles that are too tight, frequently mimics the sensation of looseness.
You're talking about the hypertonic pelvic floor.
Yes.
If we go back to the idea of a muscle's function, think of a hypertonic pelvic floor like a constantly clenched fist. Like if you hold your hand in a tight, clenched fist all day, the muscles become exhausted, rigid, and functionally useless. You can't grasp anything.
That's exactly it. A hypertonic pelvic floor is essentially a clenched muscle complex that is locked in a state of continuous spasm. Because the muscles are already maximally contracted, they cannot dynamically grip or respond during intercourse.
So ironically, this rigid muscle guarding prevents the normal encompassing sensation of intimacy, leaving the patient feeling a lack of friction. They report feeling loose or disconnected.
Exactly. So if a patient with a hypertonic pelvic floor whose muscles are already spasming and overly tight undergoes a surgical tightening procedure to fix their perceived looseness, the surgeon is going to aggressively tighten an already clenched system.
Oh, man. The outcome there has to be catastrophic for the patient's quality of life. The surgery will drastically amplify their pain, likely leading to severe chronic dyspareunia.
It underscores why patients must undergo rigorous clinical and functional assessments, often including pelvic floor physical therapy, before anyone even discusses a surgical intervention. You have to isolate the root cause of the symptom.
Absolutely. Well, let's look at this scenario where the diagnosis is entirely accurate. A patient had legitimate structural laxity, a diagnosed posterior prolapse, or a heavily scarred, separated perineal body from obstetric trauma.
Right, the ideal candidate.
Yeah. And they opt for the combined colpoperineoplasty. The data we reviewed on the outcomes of these surgeries is really striking.
From a purely biomechanical standpoint, structural repairs performed for the correct indications are highly successful. Posterior vaginal wall repairs boast an 80 to 90% success rate in eliminating the physical bulge and resolving the functional bowel obstruction.
So the patient is no longer living with that chronic dragging weight in their pelvis.
Exactly.
But the data goes far beyond the biomechanics. The review from Durji Park focused on women who underwent colpoperineoplasty specifically for vaginal laxity. They tracked outcomes using the Female Sexual Function Index, or the FSFI.
And what's fascinating there is the long-term result.
Yeah, 18 months post-surgery, these patients didn't just report improved physical friction, they reported massive, statistically significant improvements in self-esteem, body image, and psychological well-being.
This is where we see a really necessary shift in how the medical community views these procedures. For decades, anything categorized under cosmetic gynecology was broadly dismissed by purists as vanity-driven.
Right, like we were saying at the beginning.
But repairing a gaping introitus that causes painful chafing every time a woman exercises, or fixing a prolapse that makes her deeply self-conscious during intimacy, is not about vanity.
It's fundamentally about reclaiming bodily autonomy.
Yeah.
It is about restoring a person's ability to exist comfortably within their own skin without their anatomy dictating what they can wear, how they can move, or how they experience intimacy.
I couldn't have said it better. And this principle of aligning physical anatomy with a person's core identity extends far beyond repairing trauma.
Right. We should mention, because the sources are very clear on this, that we see the exact same functional and psychological imperatives in gender-affirming surgeries, which were detailed extensively in the UCSF guidelines and the Women's College Hospital Guidebook.
Yes. And just reporting objectively on what those clinical guidelines state, the penile inversion vaginoplasty is a profound example of this reconstructive alignment.
And it is a highly complex, often multi-stage reconstructive process.
It is. Surgeons surgically create a vaginal vault in the space between the rectum and the urethra. They utilize inverted penile skin to line the new vaginal canal, and they repurpose scrotal and perineal skin to meticulously construct the labia majora and a sensate clitoris.
And the guidelines note that achieving the correct anatomical function and aesthetic alignment often requires secondary procedures, like a patient might need a follow-up labiaplasty or a perineal revision to achieve the precise midline positioning and clitoral hooding.
Right, and the sources frame this not as elective cosmetic tinkering, but as a critical component of treating gender dysphoria. The primary objective is to align the external anatomy with the patient's internal gender identity.
So whether a surgical team is repairing devastating obstetric trauma, reconstructing a collapsed pelvic fascia, or providing identity-affirming care, the interventions share a common goal, which is restoring the patient's psychological and physical harmony.
Exactly. But the research mandates that this optimism is always tempered by the clinical realities of the operating room.
Right, because surgery is an act of controlled trauma, and the human body's response is never entirely predictable.
Even a perfectly executed prolapse repair carries up to a 30% recurrence rate over the patient's lifetime.
30%.
Yes. The native tissue might simply fail again, or a different section of the vaginal wall, like the anterior wall supporting the bladder, might subsequently collapse under the altered pelvic pressures.
Wow. So patients must enter these procedures with the understanding that surgery can drastically improve their function, but it cannot reverse the cellular clock to a pre-trauma state.
That is a crucial takeaway.
So if you are navigating this highly complex landscape, here is the distillation of our deep dive today. Can a perineoplasty be combined with vaginal tightening?
Yes. They are routinely combined as a colpoperineoplasty to rebuild both the internal load-bearing walls and the external structural foundation of the pelvic floor.
And when properly indicated, this combination is an incredibly powerful tool to resolve physical trauma, eliminate prolapse symptoms, and significantly elevate a person's sexual function and daily quality of life.
But it requires weeks of painful recovery and carries the permanent risk of over-tightening.
Right. Before you ever agree to a surgical reconstruction, you have to ensure that the looseness or discomfort you are experiencing is an actual failure of your anatomical structure and not a neurological misfire, a muscle spasm, or a tissue health issue that could be resolved with localized hormones, physical therapy, or thermal lasers.
I'd leave you with this thought to consider. Think about how heavily we rely on our subjective perception of our own bodies to dictate our health decisions.
Yeah.
If a compressed nerve from a difficult childbirth can make a physically strong, intact muscle feel entirely loose and disconnected simply because the brain is starved of sensory data, it really forces us to question our internal compass.
It does. How much of what we experience as physically wrong or broken in our bodies is a true structural defect, and how much is just the nervous system misinterpreting the signals?
It's fascinating.
It really leaves you wondering how many people are unknowingly seeking anatomical surgeries, enduring scalpels and stitches for what is ultimately a neurological illusion. So, keep asking those hard questions, demand thorough clinical answers before you go under the knife, and we will see you next time as we unpack another stack of research.